So today we are going to start cornea part 8, and for that we are going to start with the disform. We were discussing about the herpes simplex keratitis and its how different layers of cornea are affected. Now we are going to discuss about the disciform keratitis. So disciform keratitis, the etiology of the disciform keratitis endothelitis is unclear. So one thing is that disciform keratitis is also known as endothelitis. It affects the endothelium of the cornea. It may be the result of the active HSV infection of the keratocyte or endothelium. So also with the epithelial keratitis, it is also the active HSV infection or hypersensitivity reaction to a viral antigen in the cornea. So hypersensitivity reaction when the immune mediated reaction of the antigen. Clinical features. So what are the clinical features of disciform keratitis? Blurred vision of gradual onset, which may be associated with halos around light. So one thing, as with the corneal keratitis, it has a decreased visual acuity or blurred vision. And what we see the light, and we see the halos, the colors around the light. This is known as halos. Discomfort and redness are common but tend to be milder than in purely epithelial disease. A clear past history of epithelial ulceration is not always present, and possibility of a mimicking infection such as a xanthamoeba or fungal keratitis should be borne in mind. So these are some of the differential diagnoses we can also think of with it: fungal keratitis and xanthamoeba keratitis. So what are the signs of disciform keratitis? A central zone of stromal edema, often with overlying epithelial edema. Occasionally the lesion is eccentric. So what do you mean by lesion is eccentric? It is not central, it is somewhere around the central, known as eccentric, away from the center. And also what happened, that there is a stroma, as it is a disease of endothelium. So what will happen, it will have a somewhat stromal edema because endothelium is not functioning properly. And also if the endothelium are not functioning well, we can also find some epithelial edema as well. Large granulomatous capes underlying the edema. So and there can be the capes and which are large and granulomatous. So this is cornea. We can also find the large granulomatous capes. So we can see figure 7.13a and b. Figure 7.3a, 13a, we can see epithelial and stromal edema with Descemet membrane folds. So what can I figure out? That there is a Descemet membrane fold and there is an edema here, stromal edema. B is also showing some stromal edema. C is showing the Weasley ring, and D is scarring with vascularization from the recurrent disease. Now folds in Descemet membrane in severe cases, a surrounding Weasley ring immune. So what is a Weasley ring? Weasley ring is very important. It is a very important. A surrounding Weasley immune ring of a deep stromal haze signifies deposition of a viral antigen and host antibody complexes. Basically it is a viral antigen and what we produce in host antibodies. So these are the complexes of that, and that is associated with the deep stromal haze, and it is in the form of a ring shape. The IUP may be elevated. There are reduced corneal sensations. This may aid in distinguishing other form of infection. So basically with any viral infection, there will be a decreased corneal sensation. Heel lesion also have a heel lesion often have a faint ring of the stromal or subepithelial opacification and thinning. So what happens if the lesion is healed? It shows a somewhat opacification of the cornea and thinning. Conjunctive episode may be associated with gradually worsening subepithelial and or stromal scarring and superficial or deep vascularization. So with recurrent episode, we can get some opacification and there will be some vascularization. Mid-stromal scarring from disciform keratitis is a cause of interstitial keratitis. So interstitial keratitis is when the stroma is affected. So this is a mid-stromal scarring can cause this keratitis. So what are the treatment? So treatment broad approach to management is set out below, but the regimes should be tailored individually. Careful monitoring and adequate treatment depend on the severity of inflammation and is critical to minimize progression of scarring. Patient may be cautioned to seek the treatment at the first suggestion of recurrence, though some authority feels that minimal inflammation may not warrant treatment or can be addressed with the cycloplegics alone. So one thing we have to know about the disciform keratitis is that in case of a disciform keratitis, we use either with topical steroids, because if the epithelium is not affected, if not involvement of epithelium, steroids and topical antiviral, this is the mainstay of the treatment of disciform keratitis. Initial treatment is with topical steroid, prednisolone 1% or dexamethasone 1% with antiviral cover, both 4 times daily. As improvement occurs, the frequency of administration of both is reduced in parallel over not less than 4 weeks. So the steroids are very important, but we have to give it for the longer period of time because it is will recur. It is prudent to keep steroid intensity and duration to the minimum required for the effective control of inflammation. IOP should be monitored. So, as with any steroid, what we do is we monitor the IOP, because if steroids are used for the long term for more than 3 weeks, then it can cause steroid induced glaucoma. So, cycloplegia can be used to improve comfort if necessary. Subsequently, prednisolone 0.5% once daily is usually a safe dose at which to stop the antiviral cover. So, when we stop the antiviral cover, when we shift to the prednisolone 0.5% once daily. Some patient requires a weaker steroid such as fluoromethanolone 0.1% or loteprednol 0.2% on alternate days for many months. So as I told you earlier, that in case of disciform keratitis, we need to give the steroid for the longer period of time. We can give it on the alternate days as well, and it can be continued for many months. Periodic attempts should be made to stop the steroid altogether. With active epithelial ulceration, it is reasonable to try to keep the steroid intensity as low as possible for adequate effect with a more frequent antiviral regime. For example, initially topical antiviral 5 times daily with steroid 2 to 3 times daily, titrated according to the signs of activity of both. Oral antiviral treatment may be helpful, but its efficacy in this situation has not been established. So what happens if we have a disciform keratitis with a plus epithelial ulceration as well? So we know that disciform keratitis treat with steroid and epithelium tends to watch with steroid. In this case, we give topical antiviral as a main treatment first, and we keep a steroid to a minimum dose, or we do not give it until or unless epithelial heals. When epithelial heals, we give the steroid accordingly. Oral steroids are sometimes used in severe stromal inflammation as an adjunct or to reduce steroid-induced IOP elevation and to avoid viral promotion in infectious viral keratitis. We do not tend to give the oral steroid. We give in when there is immunocompromised, if there is a anterior uveitis, if there is a children. So that is why we give oral steroids. Otherwise, it have no role. Topical cyclosporin 0.05% may be used, particularly in the presence of epithelial ulceration and to facilitate the dripping of the topical steroid, such as in steroid related IOP elevation. So we can also use, if there is a disciform keratitis and there is an epithelial ulceration, we can also use cyclosporin 0.05% for that. Fine needle diathermy and laser technique have been reported as successfully addressing established corneal neovascularization and improving vision. Now next is necrotizing stromal keratitis. Necrotizing stromal keratitis is because of the HSV infection in the stroma. This rare condition is thought to result from active viral replication within a stroma, though immune mediated inflammation is likely to play a significant role. It may be difficult to distinguish from the severe disciform keratitis, and there may be a spectrum of disease including overlap with the neurotrophic keratopathy. So what is basically he's saying that what is a stromal keratitis? Stromal is basically when there is a active viral replication within a stroma, and it is very difficult to diagnose because the clinical signs are very similar and they are tend to be you can say that overlapping each other. As with disciform keratitis, a similar picture may be caused other infection. Signs include stromal necrosis and melting, often with a profound interstitial opacification. So, in this case, the stromal opacification is very significant. Anterior uveitis with KPs underlying the area of active stromal infiltration. So, there also can be an anterior uveitis with KPs. An epithelial defect may be present. Progression to scarring, vascularization, and lipid deposition is common. So these are not complications of the stromal keratitis. Treatment is broadly similar to that of aggressive disciform keratitis, but oral antiviral supplementation initially at the upper end of the dose range is commonly used. The restoration of the epithelial integrity is critical. So the treatment is same as that of disciform, but we tend to use oral antivirals in this case as well. So what is next is neurotrophic keratopathy. So what is neurotrophic keratopathy? Neurotrophic keratopathy is a type of keratopathy which is usually becomes sterile after any infection. Sterile after infection. So for example, a patient has an ulcer due to HSV. Now the HSV is finished or not there. So but the ulcer is still there. So this ulcer now will called as a neurotrophic keratopathy. Neurotrophic keratopathy, see also separate topic, is caused by failure of reepithelialization resulting from the corneal anesthesia, often exacerbated by other factors such as drug toxicity. So basically what happened is we know that there is a decreased corneal sensation in case of viral keratitis, and there is no epithelium fails to reepithelized because there is a anesthetic effect that is present here, and the anesthetic effect there the sensations are not going back, and the cornea does not know to reepithelize itself, and it is mostly because of the drug toxicity. So what are the signs? Signs are a non-healing epithelial defect. Sometimes after prolonged topical treatment is an early sign. So basically there is a non-healing epithelial defect. The stroma beneath the defect is gray and opaque and may become thin. Secondary bacterial or fungal infection may occur. Treatment is that of a persistent epithelial defect. Topical steroid to control any inflammatory component should be kept to a minimum. So we can see figure 7.15 and 14 now. So you can see that here is a necrotizing stromal herpes simplex keratitis with peripheral vascularization. You can see that there is a very dense stromal haze, and you can see that it is almost melting. And in this case we can see a neurotrophic epithelial defect stained with a rose bengal. So you can see this is a ulcer. So next is iridocyclitis. Iridocyclitis is basically the uveitis that is caused by the HSV. Herpetic iridocyclitis can occur without any signs of active corneal inflammation and may be associated with direct viral activity. So you may not know that this uveitis may be due to the HSV because there is no corneal signs. IOP elevation is common and is often presumed to be due to trabeculitis. So basically there is an inflammation of the trabeculum, that is why the IOP is elevated in this case. However, steroid-induced IOP elevation may be relatively common in herpetic iritis. The etiology may be missed unless there is a history of a previous herpes simplex keratitis. Patchy iris atrophy may provide a clue, and trans illumination may demonstrate subtle lesion. Aqueous sampling for the PCR is diagnostic. Treatment is primarily with topical steroid, but adjunctive oral acyclovir may be given. So let me tell you briefly what does he says. Basically, he is saying that in a case of uveitis due to HSV, why we get high IOP? There are reasons. Number one is there basically trabeculitis. There's an inflammation of the trabeculum. Secondly, there is a steroid induced glaucoma, and there is a third which is not mentioned here, but there are, because the cells are deposited in the trabeculum and they are causing blockage of the trabeculum. And how we diagnose it? We diagnose it with doing PCR. And one thing is also very important, that we give oral and acyclovir in this case. Oral acyclovir, because anterior uveitis is an indication for giving the oral acyclovir. Other consideration. So you can see figure 7.16a and b. So you can see iris atrophy in herpetic iridocyclitis. You can see a characteristic patchy appearance, and in B you can see the trans illumination. When the light is passing through the pupil, you can see that it is coming back. This is a trans illumination defect. Other considerations. Prophylaxis. When we give prophylaxis, long-term oral acyclovir reduces the rate of recurrence of epithelial and stromal keratitis by about 50% and is usually tolerated well. Basically, in case of a recurrent diseases, we give prophylaxis, and prophylaxis is usually 400 mg BD acyclovir. Prophylaxis should be considered in patients with frequently debilitating recurrences, particularly if bilateral or involving only eye. The standard daily dose of acyclovir is 400 mg twice daily, but if necessary, a higher dose can be tried based on practice in the management of the systemic hypersimplex infection. So basically, we give 400 mg BD. Just remember this. Continual use for many years have been documented for systemic indication. The prophylactic effect decreases or disappear when the drug is stopped. So once the drug is stopped, then the prophylactic is vanished. It is not that if you give the prophylaxis and then you stop the drug, it will not recur. It can recur if the drug is stopped. Excretion is via kidney, so our renal function should be checked periodically during the long-term treatment. So what are other prophylaxis? Are oral valacyclovir. 500 mg once daily or famciclovir are the alternative that are probably as effective as acyclovir. Requires less frequent dosing and may be better tolerated. So what are topical? Oral prophylaxis tends to be preferred to the long-term topical administration, as epithelial toxicity may occur, leading to mild blaring and persistent discomfort, allergy, and punctal stenosis are also potential problems. So there are topical treatment is usually not recommended because of the side effect. It can cause punctal stenosis and other problems. Vaccination. Therapeutic vaccination strategies are under investigation. Step. Long-term use of oral acyclovir reduces the recurrence rate of epithelial and stromal herpes keratitis. Next is, what are the complications of herpes simplex keratitis? And then there are, number 1 is secondary infection, number 2 glaucoma, number 3 cataract, and number 4 is iris atrophy. Basically, due to treatment, we get these two. Secondary infection. Hepatic eye disease is a major predisposing factor for microbial keratitis. So other infection can occur with the hepatic eye disease. Glaucoma secondary to inflammation or chronic steroid use may progress undetected, particularly if there is a poor view of the optic disc. Corneal thinning and distortion may give rise to an inaccurate reading on ablation, and alternative forms of tonometry may be superior in these cases. So basically, there are two types of glaucoma. I already told you, there are trabeculitis and due to steroid used. Cataract secondary to inflammation or the prolonged use of steroid, iris atrophy secondary to the keratouveitis. Now, when we do keratoplasty, what are the prophylaxis we need to take when we do keratoplasty in case of a herpes simplex keratitis? A trial of rigid contact lens is often worthwhile prior to commencing a surgery. Recurrence of herpetic eye disease and rejection are common and threaten the survival of the corneal graft. So it is not a good one if one is having a pacification of a cornea due to HSV. He is not a good candidate for keratoplasty. Why? Because of these things, there is a recurrence of the disease and a corneal rejection. Topical. So if even if what if we done the keratoplasty, now how should we avoid rejection? Then topical antivirals are given during a rejection episode, may reduce epithelial viral reactivation, but toxicity may delay reepithelialization. Prophylactic oral acyclovir 400 mg twice daily improves calf survival and should be given to patient undergoing penetrating keratoplasty for herpetic eye disease. It should also be considered in patient with severe atopic eye disease but no history of ocular HSV involvement. The duration of treatment and optimum dose has not yet been established. Immunohistochemistry should be performed on the excised tissue to confirm the presence of the herpes antigen. So basically, we can give, in a case of keratoplasty, we can give prophylactic dose for before grafting and after the graft, but the dosage and regimes are not yet determined. So that's it for the cornea part 8. Thank you very much.